Welcome to the webinar in the BHI Collaborative's Overcoming Obstacles series, Sustaining Behavioral Healthcare in Your Practice. This webinar is titled Essentials of Patient and Family-Centered Behavioral Healthcare for Older Adults. Before we get started, please note this webinar is for informational purposes only. Please consult a professional advisor for specific medical, legal, financial, or other advice. If you have questions or concerns, please send your inquiries to practice.sustainability@ama-assn.org. This series is a collection of 8 of the nation's leading physician organizations dedicated to equipping physicians and their practices with the necessary knowledge to sustain a whole person, integrated, and equitable approach to physical, mental, and behavioral health care. This webinar will cover the nuances of caring for geriatric patients and the importance of addressing their mental and behavioral health needs as they age. Physician experts will walk through patient scenarios to highlight best practices in geriatric care and actions physicians and their care teams can take to provide quality, whole person care to the patient, their family, and their caregivers. Joining us today are Dr. Karen Dianasiotis, fourth-year psychiatry resident and incoming geriatric psychiatry fellow at Johns Hopkins Medicine, Dr. Stephanie Nathel, assistant professor of medicine at Johns Hopkins Medicine, and Dr. David Barron, professor of psychiatry at Western University of Health Sciences. And with that, I will turn the conversation over to Dr. Dianasiotis.
Great. Thank you so much, Sam. Just of note, in terms of disclosures, none of our speakers today have any disclosures to share. Upon the end of this webinar, we hope that you will be able to know these following objectives. So that you'll be able to discuss key considerations of caring for the aging population, identify best practices in geriatric behavioral health integration, and describe the components of addressing patient, family, and caregiver needs. So during this webinar, I will be discussing with both Dr. Nathel and Dr. Barron 2 patient scenarios that we hope to provide information regarding caring for behavioral health needs of older adults. We will be discussing cognitive changes, medication reconciliation, and the importance of reviewing medications, as well as engagement of both the patient as well as the family member or any caregivers present. For patient scenario number 1, we're going to talk about Miss Smith. Miss Smith is an 85-year-old woman who comes in with her daughter for follow-up. The daughter expresses concern that mom was always the person who kept the family calendar and planned family get-togethers, but recently other family members have had to step in to take the lead on planning. Mom seems a little irritable and withdrawn. Her daughter is worried that Miss Smith has the beginnings of a dementia and wants to know what can be done. So I'll turn this over first to Dr. Nathel.
Great, thank you. So as a primary care geriatrician, this is kind of a bread and butter patient scenario for me, that there's not just a patient who I'm seeing, but also a family member, and that sometimes the family member is the one with more concerns or different concerns than the patient. And that's kind of always one of the first things that catches my attention is any discrepancy between what a patient and what a family member might be expressing, and kind of what is driving their concern. So, you mentioned that she's worried about dementia, but the signs that she's noticing are irritability and being withdrawn, which may or may not be a sign of dementia. And so initially, as a geriatric medicine clinician, I know I'm going to have to kind of address the patient, of course, also the family member's concerns, and tease apart the difference between these symptoms and the concern about the dementia. But Dr. Barron, I'm curious what some of your initial thoughts are in hearing about Ms. Smith and her daughter's concerns.
Well, Stephanie, I think you raise a really important point here. And in my 4 decades now dealing with geriatric patients, oftentimes the family has some very specific observations, but rarely do they sit down and ask the patient what's going on. So I think to your point about really understanding the whole patient and the family is really getting a sense from mom, from the patient on what does she think going on? Does she have concerns? Maybe she's irritable because her family members keep bothering her. I think it's really important from a primary care perspective that we allow the patient to not feel like getting old is like tantamount to becoming sick or it's a disease state. Aging is by no means a disease state. So I think the point you made is really a good one. And that's really sitting down and asking the patient, Ms. Smith in this case, does she notice any changes in her memory? What are the things that are going on at home? And really getting a good history from her. And then absolutely, as you said, bringing in the daughter and to see if what we're really seeing is potentially symptoms of some other neurocognitive issue, a mood issue, or maybe just something that's going on at home. As a family physician, do you have time to do these things? I know as a psychiatrist, we're always given a lot more time than our colleagues in primary care who oftentimes don't have the length of time that I have in a clinical session. What's been your experience in a primary care setting?
Yeah, thanks for pointing that out. That's always kind of the elephant in the room when I'm seeing older adults, is that there's a lot to cover and never enough time to cover it all. And so, I'd be lying if I said, oh, yeah, of course. I always have plenty of time to pull out a comprehensive depression screening form or, cognitive assessment to go through with every patient at every visit. I think, you kind of do the best you can to narrow down a differential diagnosis and really listen, like you said, to what the patient is saying. I think, from a geriatric medicine standpoint, initially, one of the things that I really try to do is kind of cast a broad net. So cognitive symptoms and mood symptoms are highly intertwined and are often, significantly overlapping with other medical concerns and also sensory changes that can be related to mood and also to cognition. So I think, the things that I would initially focus on with Ms. Smith and her daughter are, as you said, how she's feeling, and also what's been going on lately outside of just these symptoms. Have there been any changes in her hearing and her vision that have made her more withdrawn and less likely to participate? Has she had any other major health issues that have resulted in changes in mobility or her ability to do things on her own that might result in a change in how she's feeling about herself and her future? I keep adding to the list of things to cover in a visit. And so I think you're right, Dr. Barron, that one of the key challenges in talking with patients and families like this is, casting a broad net to make sure that you're considering, all the aspects of what might be contributing to these changes, but also really staying focused. And I don't think that necessarily means that you need to complete every comprehensive, screening or assessment form. Those tools can be helpful.
I would even go a bit further than that. As someone who has written psychometric tools, so I'll put that out as full disclosure. I really am not a huge fan of having a patient come in, particularly my elderly patients over the years, and starting to do a whole host of psychometric tools. It kind of pathologizes the setting. I much prefer to have a patient come in and just have a chat with them. And if we have the experience and we know what we're looking for, we can actually get a lot of information without turning it into, I'm being tested now. A woman of this age, as you really pointed out very nicely, is she not able to drive anymore? Maybe she can't get around. Her family members aren't able to take her to the store. So I think I really and would like to share with our audience today that don't feel like you have to come up with a number for a mood disorder or a cognitive or a MoCA, whatever it might be. I think as good clinicians, we always want to sit down, have the patient feel like we just want to get to know them. We want to hear what's going on. I always take the time in an elderly patient to compliment them in an appropriate way so that they feel like I'm there for them. And I want to hear what's going on. And I'm not taking the side, as it were, maybe of the family member who's making accusations, as it might be, but get a real sense of what's going on, not only in the patient's mind, but within the family. And I found that that not focusing on I almost always get enough information to fill something out afterwards. But really, filling out a psychometric isn't what really I think matters. It's getting to know the patient, getting a sense of what the real issues are, and how we might be able to intervene as a clinician.
If I might ask, sorry to interrupt, Dr. Barron, but if I might ask, in kind of what scenarios would you anticipate is a time for a patient to be referred outside of maybe a primary care clinic to a specialist such as yourself, Dr. Barron?
I think it's the same way in all of medicine. And that's when you feel like something is beyond your abilities. Maybe, hey, I don't feel comfortable talking with elderly patients who might have early neurocognitive deficits, or I just don't feel like I have the time. It doesn't mean that you're an inadequate or a bad physician. In fact, I always respect my colleagues who will call me and say, I think there might be a little depression, or I think it might be a family issue, or maybe some early neurocognitive things. I really just don't have the time in my practice to give my patient, what I think they need. Plus, it's been a while and I haven't really kept up on the latest and greatest in this area. So I think it's a very simple answer to a complex question. And that's when you feel you are unable to give what you would like to give to your patient, either from time or, listen, in family medicine, there's a lot of material that changes very quickly. It's hard to keep up with everything. I would certainly want any referring, particularly family physicians who I have such tremendous respect for, is I always respect those who say, you know what, I have a really good colleague who kind of specializes in this and really understands, and I want the best for you, and I'd like you to see my colleague, as opposed to, having, something that just doesn't quite feel right for you. Again, every doc always wants the best for their patient.
Yeah, I agree. That's kind of the rule of thumb that I use for so many situations. And I really appreciate that, you understand and are open to the fact that as generalists, we don't have all the same expertise that you do within your field. I think something that can be particularly challenging around referrals for depression or cognitive impairment is that the providers within psychiatry and psychology in so many communities are very few and far between. And there can be a lot of restrictions with, who will accept which insurance. And in a number of areas, I know in the area where I practice, a lot of the therapists don't accept insurance at all, which can create a lot of barriers. In case others who are listening to this have also run into this, some tips that I can think to share, just because, connecting older adults to therapists and psychiatrists is so important, are developing a relationship with some therapists and psychiatrists in your area, so you can reach out to them when you're having issues with referral. Often they know who's accepting new patients within their specialty field. Also, your Department of Aging in your community may have community resource lists of where to get mental health assistance. And I do, although I completely agree with you, Dr. Barron, that, I don't know everything, and I need to refer out when I don't know and when I need help. I also think that a lot of times with older adults, they prefer to get kind of some of their initial treatment in primary care. And so I do think that, it is okay to start offering some initial therapy, which doesn't necessarily have to always be medications. It also can just be kind of recommending that someone increase their interaction or their socialization and increase exercise. I don't know if you have any other tips, Dr. Barron, as someone who is on the receiving end of many referrals.
Yeah, no, I think there's a couple of points I'd like to pick up on that are very good. One is, you actually, as a primary care physician, have a whole lot more information than I'll ever get. You know the family, you've worked with them, stuff that I'm never going to get in initial intake. And particularly in older adults, the stigma of mental health issues is unfortunately alive and well. I mean, I think it's improving post-COVID and people coming out and talking about, it's okay to not be okay. But I think in many of our elderly populations, only crazy people went to see a psychiatrist, and that exists. And I think even referring an elderly patient, already you get a biased view of things because they don't want to look like they're crazy. You won't always get the full story. So I'm a big fan of working with my primary care colleagues behind the scenes and say, maybe here's some things you might want to consider. I think keeping them in, I am really loath to start medication. If there are very specific symptoms that would benefit from maybe pharmacotherapy, but that to me is almost never on an initial visit. We want to get a chance to see what's really going on. As was mentioned at the very beginning, what might be causing these symptoms? Is it an interpersonal action? Is it a problem of being lonely, which is an enormous issue in the elderly, even though they might be living in the household? Maybe they see how busy their family members are. Maybe they can't come over. So I think it really, really is critical that from a primary care perspective, which is where it should happen, that we get a good history of what's really going on. And again, as I started out by saying, not pathologize it right away, really find out what's happening, because in more cases than I've seen in another direction, that you don't need to add another medication onto, which oftentimes is a fairly long list as patients get older. So I really like the fact that primary care doctors should feel very comfortable, and the fact that they really understand what's going on with the patient, with the family. They can get that history, relate to the patient in a way that they're just there to deal with their overall health, of which mental health is a part of that. And I think to me, it's more important that I have primary care docs who will just call me and say, I've seen Mrs. Smith today, and, family came in and said this, I'm a little worried. And I might just say, well, maybe you might want to, here's some things you might want to follow up on. Not that I'm looking to avoid the referral, but I believe the nature of that relationship with the primary care doctor is such an important one. And as you say, many parts of the country, there's just not an availability of mental health experts, long waiting lists. People don't want to go there. With telepsych, that might be improving a bit, but I really like it staying in the family medicine setting.
That's
Yeah,
really
I agree. I excuse me. I'm lucky enough to practice in a practice where we have an embedded psychiatrist, which I realize is not the reality for so many people. In some ways, I feel like I have won the lottery. And the patients who see me have won the lottery, because we, as you mentioned, Dr. Barron, there is kind of a stigma, particularly for older adults who grew up in a generation where, accessing mental health care was not considered, normal or usual or healthy. And so, as I said, we have an embedded psychiatrist in our practice so that I can refer older adults, and they actually can see the psychiatrist within the same clinic where they see me. And that just removes so many barriers. They don't have to find some other clinic or park somewhere where there's a big sign that says psychiatry and all the emotions that may bring for the person. They just come in, to their usual primary care office and just see a clinician who isn't me. And then being in the same office, as you were saying, Dr. Barron, it just makes it so much easier for me to communicate with the psychiatrist and share my thoughts and observations so we really can move care ahead. So although that's not the reality for most people, I think trying to work towards that in the patients who I do need to refer outside of our practice, reaching out to develop a relationship between myself and the psychiatrist, to introduce myself and open the lines of communication, I think is really helpful for everyone.
Yeah, absolutely. And I think just focusing on quality of life, as opposed to focusing on some symptoms which may or may not be related to, psychopathology. Oftentimes, I think not. But if we just focus as the quality, what goes into the quality of life of an older individual? I mean, all of us have parents or grandparents, if we're not there ourselves. I'm approaching that, but I still got a little ways to go. But what goes into quality of life? It's about having relationships. Oftentimes in the elderly, they've lost, maybe their spouse, many of their friends aren't there anymore, or they're infirm, they can't get out, or they've passed away. So that sense of loneliness, but quality of life shouldn't just be, and I really like to focus being more on the positive aspects of life. But, mobility, as you mentioned, maybe they can't drive anymore. Maybe it's difficult, going out and walking around the mall, or they feel embarrassed to have a walker. So I think it's the things that we quote are the simple things, which aren't really simple at all. But what goes into the quality of life for a human being and someone as they get older, when maybe they don't remember quite so well. I mean, age-related, I tell my patients, they say, oh, I can't remember. I said, you know what? I can't remember things either sometimes. So it's not like we're saying, oh no, it's perfectly normal to remember nothing. But because we've had such a focus on, on dementia, it's been in the news, with President Reagan, and you can go on and on. I think people really worry that if they forget something, that they become a self-fulfilling prophecy. And I think our job as physicians, which we all took an oath, first do no harm. Having a patient, do all kinds of fancy memory testing that they might not do well, that we're all really losing it. I really like the idea of saying, boy, it's terrific how you're able to remember things so well. I mean, it never hurts to make the patient feel good about things. Again, we never lie to a patient, but let's focus on the positive. And I think as a family physician, as a primary care physician, if we look at what goes into the quality of life, sleep, appetite, energy, relationships, I'd like to ask people, what do you have fun doing? If someone says, I have fun doing nothing, then that's a whole different conversation I'm going to have with them. So focusing on the positive, it's actually a field called positive psychiatry, which I'm very active in. But I think it's a good thing. If we think, what would we like? We like people who say, boy, if you ask them, well, what did you have for breakfast? No, I can't remember. Well, you know what? What do you think about eggs? What are your favorite kind of egg? I mean, there are ways we can get a history where a patient doesn't feel like they're being interrogated. And I really, as a psychiatrist, have a hard time when my students or colleagues make the patient feel like they're being interrogated. I think you really need to take a bit more time with the elderly patient and let them talk a little bit more. I always look to schedule a little bit more time because they don't want to feel rushed. If they feel rushed, they'll close down. They'll just say what they think you want to hear. So I think a real pearl for the audience is to sit down, give yourself a little more time. Don't be typing at your computer. Just sit down, look at them, have good eye contact, nod with them, connect with them as a human being.
Thank you both so much for really being so thorough about this case. We're going to move on to the key takeaways and then go into scenario number 2. So I think the key takeaways, I don't want to continue to belabor what you both went over so thoroughly, but really looking at that whole person assessment for each person. So as you mentioned, talking about, what do you like to do for fun, right? What are things going on in a person's life that might be contributing to their presentation, such as changes in mobility, maybe changes in friends passing away, things of that nature. What is normal aging versus pathology, right? So I think that is what you said, really, really hitting on, being positive about the things that are going forward, and then kind of also keeping an eye out for things that are more serious and may be caused by something more serious to delve further into. The importance of collaboration with the patient first and foremost, right? And then additionally with family and caregivers. I think first and foremost, having someone feel heard and seen is, that's why we do medicine, right? That's why we're here. And then when do you refer out? And I think you both kind of hit on things that I really, really love about behavioral health integration, right? And one of those many levels of behavioral health integration is one, Dr. Natel, like you said, that co-location, having a psychiatrist embedded in your clinic. Whereas not everybody is that lucky, even having ways to consult with psychiatrists or people in the community just to run cases by them is another great option. So we'll move on to scenario number 2. Great. This is Mr. Jones. So Mr. Jones is a 75-year-old gentleman with diabetes and heart failure after a recent MI who comes in to see you for hospital follow-up. In the hospital, he was started on many new medications, and his wife is worried that they're affecting his mood. She explains that he seems kind of sluggish and also lacking motivation, which isn't his baseline, not like him. Prior to hospitalization, he was always busy working around the yard, and now he spends a lot of his time watching television. So Dr. Nothella, have you start kind of with what you think about in a primary care setting with having Mr. Jones as a post-hospital follow-up patient?
Yeah, this is another really common situation in my primary care clinic. I really like that started on a lot of new medications is bolded, because anytime I see someone who is in the hospital, my first thought, second thought, and third thought is what has happened to their medication list? And does the patient and does the family understand what has happened to the medication list? Because it can get quite complicated. I think on the next slide, we actually have an example medication list that, could be applicable to this person. And I have to say that this list, it has what, 1, 2, 3, 4, 5, 6, 7, 8, 9 medicines. That's not even anywhere close to the longest medication list that I've seen. Patients can accumulate very long medication lists, and those symptoms that he came in with, yes, could be related, of course, to any number of conditions, but I'm always, as a geriatrician, thinking about medications and which ones are new versus old, or maybe have had a change in dose. There are many medications that can have side effects that can affect the mood. And I think on the next slide, I've actually written a couple down that I just wanted to share with the audience. So, a lot of these are used very commonly in older adults. So steroid medications, older adults with chronic obstructive pulmonary disease are often started on steroids when they have an exacerbation, and they can cause certainly anxiety, paranoia. Some people have hallucinations. Whereas I have a couple of patients who absolutely love these medicines because they give them a real boost in energy. Oral contraceptives, not used that commonly in older adults, but in family practice, certainly we see those in younger adults. Beta blockers can lower the mood and also cause a lot of fatigue. Varenicline for smoking cessation can cause a number of different neuropsychiatric side effects, including nightmares. Antivirals, pain medications, which are commonly given after surgeries or falls with injuries. Epilepsy medications can cause a number of side effects. Levetiracetam, which is listed on this slide, is kind of notorious for causing all kinds of irritability and even personality changes in older adults. And then medications used for Parkinson's disease, like carbidopa, can have a number of side effects. I've had patients with a lot of anxiety, agitation, hallucination with different medications used for Parkinson's disease. So, with this patient's presenting symptoms, I would really be focused on those medications. What does the list say? What are the side effects of those medicines? And in addition to what the list says, what is the patient and family actually doing? Because we're not always very good at it, explaining what we want patients to do. And so they do the best they can. And sometimes that means they're accidentally taking too much or too little of a medicine or missing one altogether. I realized that was a pretty family medicine, internal medicine focused assessment of his symptoms. I'm curious, Dr. Barron, what your thoughts are.
Well, I'm actually very similar. I mean, the first thing I would do was I would congratulate the wife for thinking that maybe some of the symptoms she saw might be related to the medications. I would certainly want to ask the patient, what's his perspective? Has he noticed that maybe taking these medications, I see some of them were once a day, some were BID, some were TID. I mean, if this were me, I think I'd have a hard time with this. So, taking the meds, the expense of the medications, depending on their insurance, they could be deciding, am I going to take the meds or I'm going to eat dinner tonight? So I would really want to get a good perspective from both the wife, who shared this, really wonderful observation, I believe, but with the patient, what does he think is actually going on? Oftentimes I've seen some elderly patients who kind of stop living for fear of death, so they won't go out and do anything because they're afraid they're going to have another heart attack. And that's quite tragic. And then it's up to us to say, it's important. Part of your treatment is to maybe do walk for 2 or 3 minutes a day, sit in a chair and do one of those little mini exercise bike things, where it's just your feet. There's really no resistance. The other thing that I think is really important in the elderly, as you said, it's a family issue. Who's giving the medications? Can you keep these all sorted out? But the idea that every single medication has side effects. There are none that don't have side effects. And when we start adding them together, they can, even drugs that normally wouldn't have a particular side effect might have a side effect when they're added, when we have this long list of things going on. So that it's that the medication that we want to make sure that we're not treating side effects of another medication and then adding another one on, because I've seen too often when we stop treating a patient, we start treating the med list, which I think is quite tragic. And yet I've seen it time and again over the years. So simplifying it as much as we can, making sure the patient understands that all medications can have some we know more than others. Plus, as we age, our body responds a little differently. It's probably a bad analogy, but I've used it for some of my elderly male patients that, how much alcohol were you able to drink when you're 25 versus now that you're 75 or 85? That the body, it's not being sick, but we probably can't run as fast as we did when we were in 20s and 30s or ski as quickly, so that it's not being sick, but it's a part of the body allowing us, I always say, to slow down and enjoy things a bit more as we get older. But I think this medication thing, you almost can't overstate how important it is. Getting the perspective from the patient, making sure we understand, are there financial issues, getting the medications. A lot of them look alike. Some of them are very small. So even picking them up, they'll drop them. And I think that I've probably seen more patients over the, and I'm trained as a psychopharmacologist. I chair the section on psychopharmacology for the Group for the Advancement of Psychiatry. The first thing we go over is what is the ability of the patient and the family to take them, and then do whatever we can. It's always the lowest dose that's effective for the shortest period of time. And I think patients, sometimes start to believe, and I've heard this many times over the years, so they don't want to treat me. They just, I come up with a complaint, they give me a new med. So they won't even tell you some of the new complaints for fear of adding another medication added on. I always like to share with the patient that we just want medications that can potentially help symptoms that we can monitor. And we understand that some of these medications might be expensive, there might be other issues. So we're really working together with the patient at the level that they're at, cognitively, financially, otherwise. But the whole idea, again, gets back to quality of life and what can we do to improve that and avoid many of the issues that go along with polypharmacy, particularly the elderly.
That's really, really great. Do either of you have any tips, tricks, pearls for, when patients are really struggling with taking their medications and TID dosing, right? Or struggling with utilizing a pill box, or having somebody, I've had patients bring in a bag of medications, and there's pills at the bottom of the plastic bag, and this pill bottle was prescribed 6 years ago, right? So do you have suggestions or tips for people for how to best support patients and their families when they have these complex medical needs that do require medications?
Yeah,
Well,
I think.
go
Go ahead, Dr. Beer.
No, I was going to say one of the things I like to do is literally, if they bring them in, tell me, are you taking them yourself or is a family member giving them to you? So you find out who's got the responsibility from, when you're about to run out of a medication, who's driving you down to the Walgreens or, fill in the blank pharmacy there, to get a sense of what's going on. And then I'll ask them, boy, there's a lot of this stuff going on. Does this ever become challenging? And say, I think for me, this might be a little challenging. So you normalize, and they'll say, oh man, I can't remember, they look the same, I forget, blah, blah, blah. So I think we really need to get a sense of, I would almost go so far as to say, assume it's challenging and have them prove to you that it's not. Because the number of patients who are on polypharmacy with different dosing at different times, I can think of very few over 40 years plus in the field where it hasn't created some issues. And then I think we need to work with the patient and the family or the caregiver, simplify it as best we can, and work out a plan that will work for them. Sometimes a pill box, there are different ways of doing it. I am not a fan of any drug that you have to take even over once a day, twice a day, maybe. TID dosing, I think, is just, we might have learned that in our lectures in medical school that this drug only has a short half-life. But I think we need to understand from a clinical perspective, TID dosing can be very problematic, particularly when you've got a whole host of other meds on board.
Yeah, I agree. I really like how you suggested, assume that it's challenging. Because I think a lot of times patients and families, and I found this particularly with families who feel like they really need to prove or, show up as the caregiver who's dutifully caring for their loved one. They don't want to admit that it's hard for them or that they sometimes miss doses. And so kind of normalizing that, I think is really important and really helpful. I like the example that was brought up of the bag. I always have people bring in, a brown bag, a plastic bag of everything that they have, because I feel like I can't make good medication recommendations until I know what they're actually taking and what they actually have in their house. And a lot of times it is, oh, I still have this antibiotic, or someone once brought in an anticoagulant. They're not supposed to be taking that. And they weren't taking it, but they just had it in their medicine cabinet. And I think, that's a potential safety issue and opens up conversations where you can really help somebody out. But I agree that if we're recommending that someone take a medicine 3 times a day, that should really be on us as clinicians to find a better solution. If it's a short-term thing where, they really need to take an antibiotic every 8 hours for a short period of time, okay. But in the long term, I think we need to try really hard to do better for patients and families and not expect them to dose a medication 3 times a day. Just like we were talking earlier about really partnering as family medicine docs with psychiatrists and therapists, I also sometimes will find a pharmacist friend who knows a little bit more about the pharmacology, or I guess, if Dr. Barron and I shared patients, since he is a psychopharmacologist, he also would be quite knowledgeable about those medications. But sometimes medications that are recommended as being 3 times a day, I've learned to pharmacists, you can make some tweaks and reasonably dose them twice a day. And so, I only know so much, and sometimes partnering with colleagues in pharmacy can help bring about new ideas or alternative formulations that could make it easier for patients and families.
Yeah, that's a great point you raised, Stephanie. One, we were taught, and most of these medications, when we talk about half-lives and some of the pharmacokinetics and pharmacodynamics, were literally done on, middle-aged white males. It's only been relatively recently we've been looking at the effects of, hormones and how it might vary in women. So in elderly, we know many of these drugs have a much longer half-life because of metabolism issues. I always think it's important to ask the patient about other things they're taking, vitamins, supplements, grapefruit juice, that we can induce, isoenzymes that can change the metabolism. Certainly in the supplement area, I've had many elderly patients who have a bottle of Valium sitting in the night. When I get a little anxious, I just take these, it's not really a medicine. I just take it when I'm a little anxious or I need to sleep. The other point I want to pick up on that I think you said is so important, and really want our audience to consider this, is have a strategy for drugs that you can get off on. Some patients feel like, it's like I'm sentenced, I've got a 20-year sentence. I've got to take all these meds forever. I like to talk. It also engages the patient on, if you can get out and maybe walk a little bit and maybe cut back on your salt. I love my McDonald's double cheeseburgers twice a week, but things that they can do that will help them. Maybe we can get rid of some of these. So we're not just there to keep adding more and more drugs, but we want to work with them, with their family members in a very positive way, as opposed to having them feel bad that I might have missed a dose or lost a dose or whatever, on things that they can do so that there's a game plan to maybe get rid of some of these. And, quite honestly, you'd be amazed. You wouldn't because you practice in this field, but how often we can really simplify the medication list, and patients really like it. They feel like they've accomplished something. Yeah, no, I've been able to do a little 20 minutes of gardening 3 times a week. So, I don't need the pain's not so bad, so I don't need my pain meds. I'm sleeping better, so I might not need a Z at bedtime. And I think having the patient be engaged as an active participant and that what they do will make an impact. And patients I've found for the most part really love it. Now, if they say, no, I really can't get off that one, then I say, oh, okay, I understand. What's your concern about this? So again, we're working not on the patient, but with the patient, gaining their perspective, which I find just makes you a better prescriber, regardless of your specialty.
Well, thank you so much, Dr. Barron and Dr. Nathal, for both of your expertise on both of these patient scenarios. We're going to wrap up with the key points for scenario number 2. So I think a lot of these are, again, I don't want to belabor the points, but just kind of bringing it together, this whole person assessment for each patient, right? And on top of that, partnering and collaborating with the patient as well as family and caregivers. So that includes meeting patients where they're at, that includes focusing on quality of life, and that includes patient preferences as well. So I think both of those points are really important. I put it in here 3 times to really reiterate the importance of medication reconciliation. So MedRec, right? Every time I see a patient, I'm asking them, any new medication since the last time I saw you, any new medical issues since the last time I saw you. And I'm sure that you both do the exact same, especially when patients are discharged from a hospital setting, right? Focusing on side effects of medications, where can we cut down if possible, looking at how patients are taking medications, who is administering them, and where's their possibilities for side effects to get out of control or to be harmful to patients. So these are all really important. And then also, as we mentioned, or as we know, there's a lot of medical risk factors for behavioral health conditions, right? Including heart attack and stroke, right? We know that there's pretty high risk for people who have a history of MI, a history of stroke, to have things like depression. And so I think keeping that in mind on top of looking at medications, and that kind of goes back to that full person care and looking at kind of all of these different aspects on the table. Great. Well, thank you both so much for your expertise. I believe, yes. And if anybody has any questions or comments or would like to reach out to the Behavioral Health Integration Collaborative, or either of the panelists or myself, you can find our contact information right here. And with that, I will turn it over, Sam, to you.
Great. Thank you again, Dr. Deanna Sotis, Dr. Nathal, and Dr. Barron for sharing your expertise and experience with our viewers today. Be sure to visit our series page on the AMA website for information on our upcoming releases. You can also access previous recordings on our YouTube playlist. Please also check out the BHI Collaborative's BHI Compendium for a helpful framework on how you can make BHI effective in your practice, along with other actionable resources and practice case studies. Lastly, access the AMA Strategic Practice Guides on the AMA's website for implementing specific topics associated with effective behavioral health integration, pharmacological treatment, substance use disorder, suicide prevention, and workflow design. You can also find the AMA's latest guide on BHI for older adults on the AMA website by searching Integrated Behavioral Health Care for Older Adults. If you're watching on the On24 console, you can find the resource on the resource list console. If you're watching on YouTube, you can find a link to the resource in the show notes. Thank you for joining us today.